Hey everyone, we are going to get started for our morning session. So I hope you had a good morning tea. It looked very yummy. So it's my privilege to introduce Alwyn D'Souza speaking this morning. So Dr. Alwyn D'Souza is the Program Director of the Transplant and Cellular Therapy Unit at Wellington Blood and Cancer Centre, Te Whata Ora, Capital Coast and Hutt Valley. He graduated from Otago School of Medicine in 1993. He did the majority of his postgraduate training in Wellington before completing his training in Melbourne at the Royal Melbourne Hospital and Peter MacCallum Cancer Centre. He has worked at Wellington Hospital as a consultant since 2006. His special areas of interest are bone marrow transplantation and lymphomas. He also has an interest in medical education and was previously the chair of the New Zealand Joint Training Committee in Haematology. So welcome and thank you very much for doing this presentation.
Thank you. So morning everyone. Thank you. Nice introduction. We actually don't know what we're called anymore, so it's like, are we Capital Coast Health? Are we Capital Coast Hutt Valley? Are we Capital Coast Hutt Valley Wairarapa? No one really knows what the health system is at the moment, but it's a different story. So anyway, so my name's Alwyn D'Souza. I call this topic because it's a very common scenario that we come across in clinic where patients with myeloproliferative disorders or neoplasms sometimes come in and they're unaware that the condition is a cancer for various reasons, and we'll talk a little bit about why that is. But also I want to just give an overview of what the main issues are and how we go about managing it. So I thought it would be quite a good topic to call it, or the title of the topic to call it. So what are we going to talk about today? So I think probably the first thing about blood cancers is actually understanding how your normal blood works, because that then often explains the abnormalities that we see with various blood cancers. So we'll talk a little bit about the different cells that make up your blood and bone marrow, what they all do, and then we'll talk about the disorders themselves and the commonalities between the various myeloproliferative neoplasms, and then some of the differences between them as well. And also touch on why don't we call them cancers, or why don't we frequently refer to them as cancers. So, any haematology talk has to have some nice pictures of cells, otherwise it's not a real haematology talk. So anyway, you can get great pictures on the internet, but red blood cells, they're little discs. We call them, they're biconcave discs, which means that they curve in on both sides, and they're like donuts, if you like. So your red cells carry a protein called hemoglobin inside them, and hemoglobin is actually what binds oxygen. So it takes it from your lungs around your body and delivers oxygen to your body. So it's quite an important cell. If we don't really refer to the red cell count very often in haematology, the most important thing we refer to is the hemoglobin level. So if you're low in hemoglobin, we say that you have anemia, and most of you would have heard of that term. There's lots of different causes for anemia. With actually worldwide, the most common cause is iron deficiency. But actually the anemia that we see with blood cancers is for a different reason. If your hemoglobin and red cell count is high, we say you have polycythemia. Cythemia means something high in the blood, and this is related to your red cells. So that's particularly relevant to polycythemia rubra vera. So the next important cell you have in your blood are white blood cells, and these are like the immune cells in the blood. And if you like, they're the soldiers of the body, and they go around and kill off anything that shouldn't be in your body. We've got lots of different types of white cells. The most important one, or the most common one in the blood, and probably one of the most important, are cells called neutrophils. And they're mainly important in fighting bacterial infections. But you do have a whole raft of other cells which are not commonly seen in the blood, but are there, eosinophils and basophils. And then you've got other cells called lymphocytes, which are like the directors of the immune system. For myeloproliferative disorders, the neutrophil count's one of the more important ones.
So would you not expect to see many monocytes and the others?
Yeah, no, you do, but when you look at how the percentages of how they're made up, the vast majority of them are neutrophils, then followed by lymphocytes, and there's lots of different types of lymphocytes that make that up. And then monocytes, eosinophils and basophils are at much lower numbers, so you don't see as many of them. Yeah. Then we've got platelets. So platelets are clotting cells. They're part of your clotting system. They're not the only part of your clotting system. So if you have a cut, these platelets all glug together to stop the cut or stop bleeding, and then you've got clotting factors that come together and make the clot strong until the body's healed itself, and then it all dissolves away. So the platelets are the first part of your clotting system. They're these little actually I should use the pointer, shouldn't I? Probably that, yep. They're these little things here. So they're just like little blobs, or they're really parts of cells, really. But if you're low in these, then we call that thrombocytopenia, thrombo meaning platelets, penia meaning low in the blood, and that predisposes you to bleeding. If you're high in these, we call it a thrombocytosis. Now that's common in most of the myeloproliferative disorders. So what are myeloproliferative disorders? So the name proliferative really tells you what it is. So the bone marrow goes a bit haywire and overproduces the number of cells, and so it becomes overactive. And we have natural counterbalances in our body for most systems. So the systems that tell the bone marrow, actually we don't need as many cells now because you've got enough, they get switched off, and so it doesn't, the bone marrow doesn't listen to the normal signalling that it's supposed to have. So these are classified as a malignancy, and the reason for that is that the disorders stem from a clone of cells. So a clone means that they're all the same, and so by definition cancers have clones, sometimes one clone of cells or many clones of cells, but they've got a group of cells that are all exactly the same as opposed to being slight variations. So it's a bit like having, say, lots of identical twins as opposed to non-identical siblings, if you like. So some years ago, probably about 20-something years ago now, the World Health Organization relabeled them, instead of calling them myeloproliferative disorders, called them myeloproliferattive neoplasms. And the term neoplasm means cancer. But you'll hear most hematologists still refer to it as a disorder. So with myeloproliferative neoplasms or disorders, the clone of cells is at the stem cell levels, at the very youngest stages of cell development, and it's sort of around these sort of levels of stem cells. There are some myeloproliferative disorders, mainly chronic myeloid leukemia, that occurs at this level. So most of the high blood counts are associated with the cells that then grow from these myeloid stem cells. So these are the early red cells, these are the early white, platelets, and then you see these myeloid cells turn into lots of different cells, monocytes, granulocytes, or neutrophils, basophils, eosinophils. So these are what we call the classical myeloproliferative neoplasms, and there are a group of what we call atypical myeloproliferative disorders as well. They're far less common than these ones here, and we don't see many of those in our clinic. They are a little bit trickier to treat because there's not as much data on how to treat them. But these are the common ones here. The way we label them is dependent on which cell line is the predominant problem. So if your red blood cells are the predominant problem, they're too high, we call it polycythemia rubra vera. If the platelets are the predominant problem, we call it essential thrombocythemia. And if the problem is that the bone marrow has become scarred or fibrosed, we call it myelofibrosis. Chronic myeloid leukemia is its own little myeloproliferative disorder that's managed in a completely different way from all the other things. And I think Peter Brought's going to talk about that in another session, so I'm not going to talk about that today. Actually, did I? Oh yeah, there we go. Yep, sorry. So we know that these are clones of cells, and probably around the early 2000s, the first mutation that was known to cause these disorders was discovered. That was called the JAK2 mutation. And what happens with that mutation, it activates a pathway within the cell called the JAK-STAT pathway, and that seems to lead to all of the problems we get with these disorders. So in polycythemia rubra vera, that JAK2 mutation is seen in almost everyone. There's a variant of that called the JAK2 exon 12 mutation that makes up the rest of these. So that's different from these two disorders here, where JAK2 mutations make up about half or just over half of these ones. And then this other mutation here called the CALR mutation is the next most common. And then the third most common is these things called MPL or MPL. So when you look at these, we now know that we can diagnose most of our patients by actually looking at the blood picture and then testing for these three mutations. The World Health Organization actually uses bone marrow biopsies as part of the diagnostic criteria, but in someone who's got the right clinical picture with one of these, it's debatable whether it really helps you much, and it's not a pleasant procedure. So most of us don't do those very often unless we want to ask a specific question or there's something that we're not sure of in the blood picture that we want to clarify. And that's debated amongst hematopathologists who work in the lab and clinicians who work with the patients who are having the procedure about how necessary that is. There are some instances where it is really important, and we'll touch on those later. Yeah. So if you have, say, a very high hemoglobin, a positive JAK2 mutation, we know you've got polycythemia rubra vera, so it doesn't really help very much. There are some typical features we see in the bone marrow, and there are some things that may be prognostic, but actually it doesn't add that much more, and so we don't commonly do it. If it was a non-painful procedure, and not expensive, we may do it, but
nice.
What's that?
It wasn't nice.
No, most people don't like. Yeah, no, most people don't like having them done. Some people don't mind them. I have had one of my patients in Melbourne used to do the Sudoku while he was having it, and he fell asleep once while I was doing it. I don't know how he fell asleep. Yes.
Can I just ask if you've got a high red count in the blood, but when you look at the JAK2, it's also got the CARL. Would that make you think, maybe this is more primary myelofibrosis or something different?
These mutations are mutually exclusive, and so I don't think that scenario is, well, it's not likely, and I think it's impossible, actually. Yeah. Unfortunately, what we don't really understand is why one mutation can lead to three different presentations. That's still being worked out. We don't really understand why that is. Some people think it might be the dosage effect of the mutation, how much of the mutation you have in your bone marrow. Some people think there may be other mutations we don't know about that change the phenotype once you've either before or after you get the JAK2 mutation. Yeah. Okay, what have I got there? Okay, so what are the common issues that we see? Oh, I think I've actually got one slide here. There we go. So what are the common issues that we see? So the most common problem by far and away is clotting or thrombosis, and that is the main thing that we're looking to manage when we're dealing with these disorders. So clotting is very common. The risk of clotting varies by the disease and other risk factors. So we know that when we look at there's a hierarchy of risk, with polycythemia rubra vera being the highest risk for clotting. When you have elevated white cells as well, that increases the risk. Surprisingly, platelets have the lowest, having high platelets has the lowest risk of clotting, which doesn't actually make sense when you think about what platelets do. But that's actually what the literature tells us. And it's probably related to the fact that there's an inherent thrombotic tendency with these disorders that's probably not platelet dependent in reality. So the clots that patients get are both arterial and venous. So arterial clots are things like heart attacks, strokes, TIAs, which are mini strokes, peripheral vascular disease, which is where you get poor blood supply of arteries in the legs. Venous clots are deep vein thromboses and pulmonary emboli. So we see both. Arterial clots are more common than venous clots. And the reason why we don't like to think of them as cancers is these are by far and away the main problems, and this actually mainly what the treatment is directed at, reducing the risk of clotting. So it's not, we don't think of it like a cancer where you have a primary, then it spreads and it causes problems because it invades the body. They're not like that really, or not like that in the majority of patients, I should say. So that's why we don't really like the label as such. Surprisingly, bleeding can also be a problem in these disorders. And also surprisingly, it seems to correlate with the height of your platelet count. So once again, that's counterintuitive. You expect a low platelet count would cause bleeding, and it does. But actually, the patients we predominantly see hemorrhagic or bleeding symptoms is when the platelet count is extremely high, at least over 1,000. But some patients will have platelet counts over 1,500, 2,000. And that's when people have a higher bleeding risk. And it seems to be that the high platelets interfere with how the clotting factors work. And some patients will develop this thing called acquired von Willebrand's disorder. Now, von Willebrand's disorder is the most common inherited bleeding disorder in the world, but patients with myeloproliferative disorders can develop an acquired form when their platelet count is high that resolves once the platelet count has been dealt with. So that's why we see bleeding. And in some conditions, so with the CALR mutation, we see that the clotting risk isn't as high, but the platelet count is much higher and they have a higher bleeding risk than, say, JAK2 mutation patients. So which mutation you have does actually affect how the condition manifests itself as well. Okay, so so I think I'm always looking at the slide ahead, then I'm surprised when I look at that. So common issues to myeloproliferative disorders. So all of these can also lead to scarring of the bone marrow over time, and so they can lead to myelofibrosis. So we categorize patients if they have primary myelofibrosis, so they present with scarring of the bone marrow, as being different from patients who have polycythemia or essential thrombocythemia, and then down the track they develop myelofibrosis. We call that secondary myelofibrosis. So what else was I going to say about this? So with myelofibrosis, the problem, while some elements can be overactive, the predominant problem is progressive scarring of the bone marrow. And so what we see is the blood counts gradually fall away over time. So patients have the opposite problem. They have anemia where they need blood transfusions. Their platelets may drop and they may get bleeding symptoms from that, and their neutrophils might drop and they might get an increased risk of infection. So myelofibrosis, we describe it as a form of bone marrow failure where the bone marrow stops working effectively. Quite often with myelofibrosis, patients will have a very enlarged spleen and much larger than we see with other myeloproliferative disorders. And so when I see patients in clinic, say with PV or ET, I normally examine them most of the time. Mainly what I'm feeling for is how is their spleen enlarged? Do you all know what your spleen is and what it does? Yep, so it sits up here and underneath the rib cage. It's actually part of the immune system, so it deals with certain infections, but it's where all the old blood cells get removed from, and so it gets rid or destroys your old cells. In myeloproliferative disorders, it can sometimes become enlarged because the bone marrow, when you're an embryo, you actually make bone marrow. You make blood cells in your spleen and your liver. In some people, that memory of being able to do that switches on again and they start making blood cells within their spleen or their liver, and they can get progressively enlarged because of that. Okay. So how do we manage these things? So there's a lot of commonalities between the way we manage essential thrombocythemia and polycythemia. There are nuances in that, but pretty much the management is the same, but we manage polycythemia more aggressively because the clotting risk is higher. So what do we do? So we use aspirin in low doses. Aspirin has been shown to reduce the clotting risk in the vast majority of patients with both of these conditions. There's one small exception, that's the CALR mutation. If you're young with the CALR mutation, your clotting risk is actually really low, and that's the one group we don't routinely use aspirin in. But in all other groups, it's been shown to reduce clotting risk. So we know that helps. In polycythemia, the key element is reducing the percentage of red cells in your blood. So that if you look at your blood counts, if you've looked at your blood counts on the Manage My Health or paper copies of your blood forms, you'll see a parameter called the HCT or hematocrit. So that's the thing that tells us about what percentage of the red cells are of the total amount of blood. So that includes the fluid component of your blood called plasma and the other white cells and platelets. So studies have shown that if you reduce the hematocrit to under 0.45, the clotting risk is substantially reduced. And they compared different levels in different studies, but we know under 0.45 carries the best reduction in risk. That was the target that the studies used. Now, some people extrapolated that data to say, well, men and women have different hematocrit levels. So men have a higher hematocrit than women in general, in the general population. That's a testosterone-driven effect. And maybe women should have a lower target level than men. That's not actually ever been proven. In fact, I used to do this, and then when I looked at the literature, I thought, well, I actually don't know whether that makes a difference or not, so I'm not going to push that as hard. So I actually just aim for under 0.45, but some people will aim for under 0.42, sort of extrapolating what normal physiology is in patients. And we can do that in two ways. We can either just remove blood from people, which is the simplest thing to do, and if people have got good veins and they tolerate that volume, it's a really easy treatment. But sometimes people don't have good veins or they don't tolerate it, and sometimes because they've got other medical problems where removing that amount of volume can cause problems, in which case then we might use medication for it. The most widely used medication around the world is frontline still is a medication called hydroxyurea or hydroxycarbamide. So a lot of patients get confused with that. So in New Zealand we've always called it hydroxyurea. A few years ago Pharmac brought in a brand called what's labelled hydroxycarbamide, and some countries call it hydroxycarbamide. It's exactly the same drug, it's just a different name. So when I worked in the UK, people called it hydroxycarbamide over there. So, but I have had one patient who's refused to take it because she said that no one told her she was getting this new drug. And I think that we just prescribed hydroxyurea, she got hydroxycarbamide, and I saw her in clinic a couple of weeks ago, and she's like, I was just adamant she's not going to have it. So anyway, we've sort of worked our way through that. Okay, so why do we try and remove the hematocrit? Because it has been shown to reduce the thrombotic risk. So that's the key factor. We know that because arterial clots are the most important or the most common clots, that actually attending to other risk factors for arterial clots reduces your risk as well. So what we call the cardiovascular risk factors are important: high blood pressure, diabetes, smoking, high cholesterol. So all of those things can contribute to clotting risk, and that's where your GP really comes into play, because they're very used to managing these things, much better than haematologists are. So in that, I normally will say to your patient's GP, please make sure that these things are managed optimally, because that will reduce your risk. Okay, so that's that. Yes?
Just one question. So you're kind of measuring the hematocrit versus the platelet count, or do they both usually?
So we do it. So yeah,
high?
Good question. So we measure a full blood count or complete blood count, which is the hemoglobin, hematocrit, the platelets, and the white cells. So we measure all of those. Now that's a really good question, because we don't just look at one parameter, we look at all three parameters, because if you have polycythemia or essential thrombocythemia and your white cell count is elevated as well, that increases your clotting risk. And if you have all three, it increases it. So we actually look at all three parameters. Now, one of the main reasons I put people on hydroxycarbamide, I'm trying to make myself say that name as opposed to hydroxyurea, is that some of my patients with PRV are going on really nice with venesections, and then their white cell count starts to go up. And we know that venesection doesn't affect the white cell count. So what I'm using hydroxycarbamide for in that situation is to bring the white cell count down as well to lower the clotting risk. So we look at all three things. Yeah.
Sorry.
Yeah.
It's okay, I don't. All right. So the hydroxycarbamide.
Yeah.
Does that affect the white cell count
Yeah.
more than lowering the hematocrit?
Does all three.
But you would need to take more hydroxycarbamide in order to see more of an effect on the hematocrit.
No, it doesn't.
Well, I'm only talking from my experience.
Yeah, it doesn't necessarily work like that. But hydroxycarbamide is an antimetabolite oral chemotherapy. The way it works, it inhibits DNA synthesis, and we actually see the effect on the white cells and platelets quite quickly, usually within a week or so. But the effect on the red cell count takes a lot longer to see. Now, the reason for that is that the half-life or the lifespan of white cells and platelets is actually very short. But for red blood cells, once they've gone out into the circulation, they actually last there for 3 months. So any change you do with your treatment, you're only going to see the effect of that, or the full effect of that on your red cells 3 months later, whereas the other things you see quite quickly.
But sorry.
Yeah.
There's only a small group.
Yep.
But is the danger that you want to try and control your hematocrit?
Yep.
But you have to take more hydroxycarbamide.
Yep.
But then your
White
white
cells
counts
drop.
become too low, so
Yep.
surely we need white blood cells.
Yeah, that's what's right. So with hydroxycarbamide, the main potential risky side effect is that it's there to suppress your marrow, but you can overdo it. So that can mean your white cell count drops and your platelet count drops, and that can then mean your risk of bleeding goes up or your risk of infection goes up. So we're balancing controlling the blood counts and trying to not allow the blood counts to drop. So in some people that can be really tricky, because in order to control one of the cell lines, some of the others drop, and then we're having to juggle those two competing risks. Yeah, and that's it. I've got a few patients like that. Yeah.
It does nothing to my platelets.
Yeah. Yeah.
If I take one extra tablet a week,
Yeah.
I then in 3 weeks have hardly any white counts.
Yeah. So what I would focus on would be the hemoglobin and white cells, partly because there's still debate about how big a contribution platelets make. In fact, there's a bit of a divide in the world about this, in that in North America, most of the myeloproliferative disorder experts say don't ignore the platelet count, just focus on the other two cell lines because it doesn't make enough of a difference to matter. In the rest of the world, we still look at it, but I've become more relaxed about it because of that, because it's not as important as the other cell lines, and so I focus on those ones. So in some of my patients, they don't have perfect control, but their hematocrit's okay and their white cell count's okay, and I leave their platelet count alone because I'm not going to get it into the normal range without them dropping their counts too much. And the other thing to remember is when we venesect patients, we actually make them iron deficient, which is really helpful for controlling red cell production, because if you're iron deficient, you don't have the substrate to make cells, but it's not so good for your platelet count, because one of the side effects of iron deficiency is the platelet count goes up. So often patients will have a combination of their platelets being high from iron deficiency as well as the underlying myeloproliferative disorder. Yeah. Yeah, so tricky. That's I've got a few patients like you where we're sort of really trying to juggle getting the right dose or the best dose we can, but knowing that if we push it too much, we're going to see. Yeah. You're the sort of patient that I worry about most when I'm sick, because most of my patients, you put them on a dose, you titrate it over the first 2 or 3 appointments, and then you just leave them alone and it's fine. But I've got a few patients like yourself where we're juggling all the time because they're not quite right, and we can't get optimal control, but we aim to get the best control we can. Yeah. Okay. What have I done here? Oh, wonder, that seems to not be, maybe I need to click on that. There we go. Okay, so we talked about risk stratification before, that not all patients are equal for their clotting risk, and we know that polycythemia rubra vera has a higher clotting risk than essential thrombocythemia, but within those groups as well, we risk stratify people. So what are the other things that are really important? So for clotting, age is really important. So we know the clotting risk, and the whole population goes up as patients get older. We know that once you get to around 60, that risk goes up substantially. So when we stratify risk in patients, we think about their age as well as their underlying diagnosis. And then the other very important thing is, have they had a clot before? Because if they've had a clot before, then their risk of further clots is much higher than if you've never had a clot. So those, the three biggest things are diagnosis, which one of these things you have, the age, and whether you've had a clot before. The other thing that's important is the type of mutation you have. So the JAK2 mutation, which is the most common one, also carries a higher clotting risk than the other mutations. So if you have one of the other ones, we're not quite as worried about clotting as if you have the JAK2 one. So we do risk stratify people according to those things, and also cardiovascular risk factors. So if you've got diabetes, you know, you've got angina, you're sort of 60 odd, then you're in a much higher risk than if you have none of those things and you're 30 or 40 years old. So that's quite important for how we manage things. So for essential, I might read it from here actually, my eyesight's not so good anymore. So for essential thrombocythemia, those risk factors that I've already described, and then you've got patients in, say, the lowest risk group that don't have a JAK mutation, there's no history of thrombosis, and they're young. And those patients we're much more relaxed about. So one of my patients with CALR mutation, they carry a platelet count, if they're not treated, of about 2,500. But she's young, which is great. And in her, what we're mainly worried about is bleeding risk. And so what we've agreed on doing is managing the platelets just to get them under 1,000. We're not trying to normalise them because she doesn't really need that from a clotting risk. We're just trying to manage the bleeding risk. And the medication she's on, interferon, she doesn't really like. So we try and minimise the dose by just aiming for that as the target, because at the moment that's her main issue, is bleeding, not clotting.
So we've got bleeding. Where
Yep.
are we bleeding from?
It's usually what we call mucocutaneous bleeding, which means mucosal surfaces like, you know, the inside lining of your mouth, your nose, the gut, urinary tract, and then bruising. Yeah. So mucocutaneous we call it. As opposed to, say, there are different patterns of bleeding. Say, for instance, if you have haemophilia, where you have if you've got severe haemophilia, an absence of factor VIII, which is one of your clotting factors, they don't get so much of that sort of bleeding. They mainly get what are called deep muscle and joint bleeding. So bleeding inside knees, hips, elbows, things like that, or bleeding inside muscles like the thighs. So it causes a different type of bleeding. With these disorders, it's mainly skin and mucosal surfaces. So that can manifest as bleeding from the bowel, vomiting up blood. Mainly it's nasal and mouth bleeding though, yeah. Or period bleeding is the other thing, yeah.
With long flights, would we have to be more careful?
Yeah, so taking into account the whole package, and really we don't actually have any data to say what people should do in this situation. So I normally say, well, drink plenty of fluid, because we know that staying hydrated decreases the viscosity of your blood. That's important. Move around the cabin if you're able to. I always like to go for aisle seats because they're much easier. And it's unclear whether actually using blood thinning agents for the flights is helpful or not. So normally if patients ask me about this, I say, look, I don't really know. And depends on their background. If they've had previous clots, then it's much easier decision to say, yeah, we should put you on something. Most patients will be on aspirin as well, remember, so that's good. And the risk on flights isn't arterial, it's venous clots, so we'd look at that from an overall package. It's a little bit easier now because in the past, our blood thinning agents that we would use in that situation were injectable agents, which are a real drag if you've never given yourself an injection before. But there are some oral agents now as well that are much easier to use. So it isn't, if you need to use them, they're much easier to use. But it's an evidence-free zone, really. We don't really know. Okay. If patients do develop a clot, they then get changed on to one of these blood thinning agents. So in the past, it used to be warfarin to first clotting. The problem is warfarin, while it's an effective drug, it's a really hard drug to use because the levels can go up or down with your diet, different medications you use. We know that at Easter time when people eat chocolate, their INRs go up, and so it's a really difficult, even when people are really well controlled, they're only in the therapeutic range about 60% of the time. So that means about 20% of the time they're too high, 20% of the time they're too low. There are now what we call novel oral agents. In New Zealand we have two that are funded, dabigatran and rivaroxaban. Much easier to use because you just put people on a standard dose and it's very predictable what their effect is, with a few exceptions to that, but they're much easier drugs to use. So for most clotting, those are the preferred options now, but there are situations where warfarin is still better, or some of the injectable drugs may be better in certain situations. There is this drug called anagrelide. I don't know whether anyone in the room's on anagrelide. Yeah. Right. Right, okay. And that was because you're young or because another reason? Do you remember?
Because I was young.
Yeah.
Yeah, but I started to experience heart
Palpitations?
palpitations,
Yeah.
so I was only on it for 2 years.
Yeah, so anagrelide is a targeted drug that targets the platelets or the platelet-making cells. So it's quite good as it focuses in on that. And we've mainly used in the setting of people not tolerating hydroxycarbamide, or we've been reluctant to put them on it because they're so young.
I think that was another reason.
Yeah, that would have been the other reason. And I'm going to get onto that with one of the hydroxycarbamide slides, but the problem is it is associated with palpitations and heart rhythm disturbances, so it can be tricky. In older people, it can be very tricky. It's also not been shown to be quite as effective as hydroxycarbamide. Hydroxycarbamide is better for reducing arterial events and also reduces bleeding events. So it's a better drug than anagrelide, but some people anagrelide is the best drug for them because they don't tolerate hydroxycarbamide very well. Oops.
You're having a clot.
Yep.
How would you recognise that?
Yeah, that's another good question. So if you're having a heart attack, chest pain by far and away is the most common symptom, sometimes indigestion. My dad
So
was...
it's like all or nothing. You don't sleep.
Yeah, you notice something is wrong. Yeah. They're not subtle, these things. So a heart attack, severe chest pain, sometimes it manifests itself as indigestion. My dad was a GP. When he had his first heart attack, he was in the garden and spent about an hour with some indigestion and then realised he was sweating and then thought, oh my God, I'm having a heart attack. But it took him like an hour before he realised that.
Wow.
Luckily he was all right at that time. So strokes are very obvious, sudden weakness down one side of the body, that you can't miss that. What's that? Well, you can, but usually it's very obvious. Clots in the leg swells and is painful and it usually looks different from the other one. Clots in the lungs most commonly present with breathlessness or chest pain. Very occasional they'll present with people coughing up blood, but those two things are by far the most common things. Yeah. Okay, so hydroxycarbamide, we still use this because in most people it's really well tolerated and we've got the best evidence for it, but it's not good for everyone. So we know that there are side effects. There's that word mucocutaneous again. So people can get ulcers in the mouth. I've had one patient who had really significant ulcers actually, and that's why we stopped it in the end. Probably the most problematic ulcers is it can cause skin ulcers, particularly around the ankle, and if it's related to the hydroxycarbamide, we generally have to stop the drug because the ulcer won't heal up unless we do that. In most people it's very well tolerated though. Can colour your fingernails, so I've got some patients who their fingernails go brown with it, and occasionally can cause a skin rash, but not very commonly, but it does occasionally. I've got a small group of patients who have had a major reaction to it, and it usually manifests itself as a flu-like illness within about 6 weeks of starting, and very commonly it's associated with inflammation of the liver or hepatitis. And in those people, they can't use it. I had one patient and I wasn't sure whether that was the hydroxycarbamide that caused it. So we stopped the drug, let the symptoms settle down, and then we started her on it, and within 2 hours, she had the same symptoms again and got really unwell with it, so we canned it after that. But that's a really horrible thing, and I probably see one of those reactions maybe every 2 or 3 years maybe, but we've got a lot of patients on this, and it's a rare reaction. What happens to your blood? So one of my patients one day, who came to this talk 5 years ago actually, asked me in clinic, why the blood film's got this thing called stomatocytes on my blood film. Well, why have I got that? And I was thinking at the time, I remember thinking this, I hadn't heard of this on hydroxycarbamide, and the most common reason we see that is actually alcohol. But he actually doesn't drink. And so when he told me that, I went back and looked up and went, oh yeah, no, it's the hydroxycarbamide that's causing that. The most common thing we see is the red cells get larger. So there's a parameter on your blood count called the MCV, and that's the mean cell volume. So predictably that gets larger. I sort of use it as a check to see if my patients are actually taking the drug, because in most people, their red cells get larger. If they don't, that's when I think, I wonder whether they're taken. And people on really low doses, it doesn't. Or if people have got reasons why their red cells are smaller, sometimes it normalizes the size of the cells. But in most people, the cells get larger, so it's a good way of checking compliance. And this is what we were talking about before, so it can suppress these other blood cell lines. So that's probably the thing that we worry about the most, because that can be dangerous, and we have to be careful with that. The neutrophils actually get more segments on them than normal. So neutrophils have like multi-lobes, usually 3 or 4, but quite often with hydroxycarbamide they get 5 or 6, which is a typical feature of this as well.
Sorry, nothing to worry too much about when those things pop up?
No, that tells us that the drug's doing what it's doing. So it actually causes the bone marrow to look, what we call it, has megaloblastic features, which means the cells get larger, they get more lobated. Sometimes it affects the platelet-making cells as well. But no, those, if you weren't on hydroxycarbamide, that might indicate that you've got either B12 or folate deficiency. But on hydroxycarbamide, it's a predictable, routine thing to see. Yeah. This is what we don't want to see in your blood. So this is what's called a blast cell, and that may indicate that it's progressing to an acute leukemia, which is one of the complications, which is, so when I talked about most patients don't behave like a cancer, the two exceptions to that are if you progress to myelofibrosis, because it does significantly reduce the life expectancy, or if it progresses to an acute leukemia, which happens in about 1 to 5% of patients. It's not common, but we do see it. So this, if I see that in someone's blood, then I start getting worried about it. Yeah. So, okay, that was my next slide actually. So these disorders have an inherent risk of progressing to an acute leukemia. It's in a small percentage of patients, but it's large enough where we do see this in some people. There's been a lot of debate in the medical literature ever since I was a registrar about hydroxycarbamide and does it increase the risk of leukemia or not. The older treatments we used for myeloproliferative disorders did increase the risk. So particularly what we call alkylating agents, we know that increased the risk above that 5%. And so when hydroxycarbamide was developed for this disorder because it works in a different way from the alkylating agents, and you wouldn't predict that it would cause leukemias, but there's been a debate about it ever since. Now, does it cause it or not? The answer is complicated, but the answer is almost certainly no. Or if the risk is increased, it's a very small risk that we haven't seen in long-term follow-up data. So there's been a number of trials that were done in the early 2000s comparing hydroxycarbamide to other treatments. And what they didn't see was that the patients who got treated with hydroxycarbamide had an increased risk of leukemia. So that's quite reassuring that either there isn't a risk, or the risk is so small that over long follow-up periods we're not seeing a difference in that. But it is always the thing that, in my experience, is the most concerning to patients about whether this may cause the leukemia risk to go up. And it's one of the reasons why you would have probably been put on an agrolide when you were younger. So on first principles, we try and avoid hydroxycarbamide in younger patients if we can, just because even though we don't have data to say it does do that, we've been burnt before, and if you don't have to have it, then we don't use it. Having said that, it doesn't worry me if someone does need to go on it, because it is a good drug. It's the best tolerated out of all the drugs we've got, and it's the simplest to use. So it's good, but we just have to be cautious with how you use it. Now, getting onto that, there's a few other drugs that we'll just talk about. 2 minutes? Okay. We've been doing 10. Oh, yeah. End, yeah. I guess we've been doing questions as we go, so that's probably okay, actually. Actually, I'm going down the other way. So in general, we use hydroxycarbamide for our high-risk patients. So polycythemia rubra vera if you can't control it with venesections, and then essential thrombocythemia if you're in one of those high-risk groups. That's when we use it, but we don't use it for the lower-risk groups. The other thing that we know, we do use hydroxycarbamide for non-malignant conditions, things like sickle cell anemia and cyanotic heart disease, and we haven't seen an increase of leukemias in those groups, and they're on it long term as well.
Should I be worried if my doctor puts me on that drug because it is chemotherapy, which is like cell death, so that's like boring yourself?
Yeah, no, the short answer is no. We can talk afterwards if you like. The short answer is no. There are times when it is the best drug to use, and yes, it does inhibit cell production, but your predominant risk is clotting, and so by far and away the clotting risk outweighs the risk of actually using the drug. Yeah. Yeah. Yeah, we don't really know. It's not very targeted. It actually affects DNA synthesis, so it affects fast-growing cells, which is mainly your bone marrow. One of the things I forgot to mention is there is a higher risk of skin cancers and myeloproliferative disorders that seems to be worsened by hydroxycarbamide as well. So I've got a few patients who've been on it for a while whose skin cancer has become a problem. It's very hard to pick that apart from their lifestyle, because in New Zealand, as you know, I'm probably just of an age where people started to worry about going in the sun. But like my wife's a similar age, and she used to cook in the sun when she was a kid. So in New Zealand, we've had a lot of skin damage as well, but that's another potential contributor. Yeah.
It's at the lighter end, isn't it?
It is. It is. So yeah.
Yeah, because you're taking an oral.
Yeah.
In a big machine, so the radiation's not.
Yeah, and
That's how I kind of helped myself.
yeah, and I think and remember, I've described it as an anti-metabolite, which means it interferes with metabolism, as opposed to some chemotherapies that bind to DNA and stop replication, or can potentially damage the DNA because they bind irreversibly to DNA. So the mechanism of action is one of the reasons why we're more relaxed about using it, as opposed to drugs like cyclophosphamide or melphalan, which we do use for other cancers, but we don't use them long term the way we would with a myeloproliferative disorder. So the mechanism of action is the thing that tells us that it should be okay. Yeah.
And you are on this drug forever until you die?
Unless you progress to myelofibrosis. Yeah.
Unless you get worse.
Yeah. Which hopefully is not going to happen. But okay, so interferon. So interferon's an interesting drug. It's sort of a dirty drug in that, well, a lot of our drugs are dirty drugs in that they do lots of different things. It suppresses, the reason we use it in myeloproliferative disorders, it suppresses your bone marrow, but it actually has an immunomodulatory effect on the immune system as well, and has a few other blood forming or blood vessel forming attributes as well. What we're using it for is to suppress the myeloid cells. One of the big advantages of it It's not a chemotherapy. It's safe to use in pregnancy, so it's our go-to drug for pregnancy. And what was the other thing I was going to say? I was going to say something else about it. I can't remember what I was going to say now. Yeah, so it's safe to use in pregnancy. The other interesting thing about interferon, now standard interferon is no longer available, which is great because it's a really terrible drug to take. It's the most common symptoms are flu-like symptoms, and it happens universally in people when you start and as you increase the dose. And most of the patients, those will settle down and go away, but some people actually just feel like they've got the flu continuously. The long-acting forms now have replaced the short-acting forms. We've been lucky with myeloproliferative disorders that when these long-acting forms came available for more common diseases, the companies stopped making the short-acting forms. So Pharmac had to fund the long-acting forms because some of the patients who are on this had no other alternatives. But it is tightly controlled for funding purposes. You can only get on it if you can't use hydroxycarbamide or anagrelide. There's a theoretical advantage behind interferon in that, remember we're talking about these mutations, we know that in some people, about 20% of people, it reduces the burden of mutations, and in some people those can become undetectable. Now, for some types of cancers, that's how we measure response. We don't know whether there's no data to say that reducing the clone size affects long-term survival at this point in time. Now, one of the reasons that's going to be hard to prove in myeloproliferative disorders is because most people live a really long time with them and they don't die from them if they're well controlled. So to prove that something has a survival advantage is actually really hard because you've got to do long follow-up. So there's a theoretical advantage as to why it might be good, but we don't know for certain it's better than the other drugs. What are the negatives? It's an injection. Not that hard to give though, and if you think about patients who take insulin, most patients say, I can't do that, and then after about a week they're doing it quite merrily without any problem. So it is an injection. It's really easy to learn how to do the injections. Those flu-like symptoms are much less common with the longer-acting forms, luckily, but some patients still get it with the longer-acting forms. So the pegylated form, or the long-acting form, is better tolerated. The things that I worry about, and I think I've seen all of these, is it's associated, in fact in the US and Canada, it's got what they call a box warning. It's associated with life-threatening neuropsychiatric side effects. In about 20% of people, they can get depression, anxiety, which can be very severe. So my patient who had the hydroxycarbamide flu-like illness that I then re-challenged her and she got a hepatitis with it, we stopped that. I felt she was too old to use anagrelide, so we went on to interferon, pegylated interferon, responded beautifully. She was the most vivacious patient I have, and about 9 months into treatment she came in and she looked like a different person. And her husband said, look what the drug has done to her. She was just flat and very depressed. And that was from the interferon. We stopped it and she got better. She's back to her normal self now, so that's good. So that's a real problem. About 20% of people. Because it modulates the immune system, some people can get autoimmune complications. In fact, I share an office with one of my colleagues, Phil George, and I heard him on the phone yesterday to one of his patients who's developed an immune overactive thyroid, and almost certainly it's from the pegylated interferon. That's not very common though, it happens in less than 1% of people, but it is something that we see. It can also cause hepatitis as well. In most people it's pretty well tolerated. One of the other advantages is that we treat to reduce the clotting risk, but hydroxycarbamide does almost nothing to the other symptoms. Interferon at least reduces itching associated with these disorders, which some people it drives them mental. So that is one nice thing about it. I think I'm running out of time, so I better move on. People have developed scoring systems. One thing that we didn't appreciate until probably about 10 or 15 years ago, we mainly focus on the clotting risk, but in some people they'll have quite a high associated disease burden, so they'll have other symptoms. You're more likely to have other symptoms like fatigue or night sweats or weight loss if you have myelofibrosis compared to the other ones. Those symptoms in myelofibrosis have prognostic significance as well. People do worse when they have them, but not for the other two disorders. That's what I've just said. The itching, quite commonly people notice when their skin gets hot, they itch more. So in summer, they itch more. If they have a hot shower, they itch more. If they have a hot bath, they itch more. Nothing's really great for using it other than ruxolitinib, which I'm going to get on to next. So myelofibrosis, finally, is the most problematic of these disorders because the bone marrow stops working. The prognosis is shorter, although even within myelofibrosis, there are a number of factors which some people will actually have quite a long survival, more than 10 years with it, but others will have a very short survival in less than 2 years. So it can be very tricky, this condition. And the problem is all the blood counts drop away and then people get a lot of symptoms associated with it. These are some rough clinical scoring systems that we use. This is actually quite a useful thing because it's really easy to check in clinic. You know, what's the patient age? Do they have anemia? What's their white cell count? Do they have blasts in their peripheral blood? Do they have constitutional symptoms? So a really quick screen of people. There are fancier prognostic scores now that involve different genes that you might have with this, and we use those predominantly for decisions about bone marrow transplant. So myelofibrosis, if you're in the poor risk groups, the more advanced groups, their life expectancy is less than 2 years. In some of those people, we will offer them something called a bone marrow transplant, which is potentially curative treatment for this. Unfortunately, most of the patients who have myelofibrosis are of an age where that becomes too risky to do because it's a tricky treatment to give and many people die of complications, or they have other medical conditions that make it too risky to do. But that's where we mainly use all these other molecular markers. The treatment is mainly supportive care. When I last gave this talk in 2000, and then whenever it was, ruxolitinib was just about to be funded by Pharmax, and now we've had it for 5 years. It's a really good drug for myelofibrosis in certain situations. The main thing it does, it reduces symptom burden. So weight loss, night sweats, it's really good at turning those around. It also reduces the spleen. It's not been shown to alter the natural history of the disease. So if you're progressing to an acute leukemia, it's not been shown to prevent that or the amount of fibrosis. And it's not, in individual trials, hasn't been shown to affect survival. But when you pull all those trials together, there is an improvement in survival. And it's probably the people who get those wasting symptoms of weight loss and night sweats that are probably the ones who actually it improves survival in the most. It is a good drug. Once again, it can have problems with low blood counts, and you've got to be careful with that. And it can also suppress the immune system to make you more susceptible to other types of infections as well. I might skip over the transplant bit, and we can talk, if people want to talk about that, we can talk about that after the session. But otherwise, I might call it quits there. Do people have any other questions they have? Or should I do the summary slides? Maybe I'll do the summary slides actually just last of all. So these are clonal disorders, that's why they're called cancers. The predominant problem is clotting, arterial and venous. Some people can have bleeding symptoms as well. There's a risk of progressing to myelofibrosis with essential thrombocythemia and polycythemia, and a small risk of progressing to AML. But the treatments are predominantly targeted at reducing clotting, thrombotic risks. And in myelofibrosis, it's mainly symptomatic treatment of the condition, and in a select few patients, transplantation. In the last talk, one of my patients who had polycythemia rubra vera, who then progressed to myelofibrosis, we transplanted him, and he came to the talk and sat in the front row, which was quite gratifying. He's like a cheerleader in the front row. He was the one who asked me about the stomatocytes. Anyway, just a bit of hematology humour. Right.
Thank you so much. We might actually have to wrap up because we'll have people entering the room soon for the next talk. So thank you so much. We really appreciate your time and expertise. And I'm sure I can say on behalf of everyone it was really informative. And thanks for answering our questions throughout. Thank you very much.
Thank you.
And you all have about 5 minutes to get to your next talk. So if you need help figuring out what rooms are next, just come and ask Nick or I.